Hello, everyone, and welcome to today's panel discussion, Trends in Digital Health. My name is Beth Rowley, and I am the Operations Director for Princeton Innovation Center Biolabs. I'm here with our events manager, Michelle Romer-Schoen, and we would like to thank you for attending today's event. I know you will find it interesting. The next slide. Princeton Innovation Center Biolabs opened for business in 2018 with the mission to foster innovation, collaboration, and entrepreneurship in New Jersey. We have over 30,000 square feet of laboratories, meeting rooms, offices, and co-working space. And we are here to make it easier for new science-based companies to get started and to grow. The co-host for today's event is the Princeton Entrepreneurship Council of Princeton University. The mission of the Princeton Entrepreneurship Council is to engage the Princeton entrepreneurial ecosystem through education, mentoring, and funding. A big thanks to the PE staff for their work in bringing today's event to fruition. We've been in the world of virtual events for long enough. I'm sure you know how the logistics work. If you have a question for our panelists, please type it in the Q&A section at the bottom of your screen. If you are having technical issues with the webinar, please let us know about it using the chat section. And you can also use the chat section to let other attendees know that you are here. Now I would like to introduce the moderator for our panel today. Dr. Kimberly Newell-Green is a pediatrician and associate clinical professor at the University of California, San Francisco, and the past president of the San Francisco Marin Medical Society. She is the former chief of healthcare innovation at Kaiser Permanente in San Francisco, where she worked as a general pediatrician for over a decade. She is working to transform healthcare by leading and supporting innovations in digital technology while keeping humanity at the center of health and healing. At this point, I will hand things over to Kim and let her introduce you to the panelists. Thank you again for attending today's event. I know you will enjoy the discussion.
Thank you so much, Beth, and welcome again to all of our diverse viewers here today. As Beth said, I'm Dr. Kim Newell-Green, and aside from the things that she mentioned about me, I'm also proud to be Princeton 94 and very honored to have been asked to moderate this panel for the Princeton Entrepreneurship Council and the Princeton Innovation Center Biolabs. It is such a pleasure to be here today with these speakers who are three real innovators in the digital health space. And what an interesting time to be talking about digital health technology. More than a year into the COVID-19 pandemic, when certain tools like telehealth have had an unexpected boost as barriers to use were dropped in these unprecedented times. It's also a very exciting time in the life cycle of an industry that's really still very immature. Since its inception, a lot of the hype in digital health has been around apps and personal health and wellness tools. Now we have many of the key ingredients to really up-level the work we do here with processes and the approach, to add research and rigor, and to find compelling business cases so that we can use digital tools to meet the so-called triple aim, to really improve the experience of healthcare, to improve the quality and the outcomes of healthcare, and vitally to reduce the cost of care as our healthcare system really careens towards financial disaster. I'd like to start today by having our panelists, Drs. Carolyn Jasic, Jean Drouin, and Sharon Hajazi, introduce themselves. And then we'll dive into some meaty questions about their experiences in the digital health space. Let's start with our two MDs. Carolyn, you started at the Princeton School of Public and International Affairs with an interest in becoming a health economist, and then you ended up as an adolescent medicine doc at UCSF. Then you pivoted into the business of digital health, and you eventually landed your role as the Chief Medical Officer of Omada Health. I'd love to hear that whole story, but for the purposes of time today, can you tell us about Omada, which is really one of the stars in digital therapeutics, and your role there as the Chief Medical Officer?
Thank you, Kim, and thank you for having me. It's always really fun to come back to Princeton, albeit virtually this time, to share some knowledge and experience. So Omada Health, where I work currently, is a digital health company. We've been around for about 10 years. And what we're really trying to look at with the term digital therapeutics is develop clinical grade evidence-based solutions to put out in digital health. And I think you said it even better than I can, that the beginning of our industry really focused a lot on apps and kind of consumer-based tools for healthcare, which were useful in their way. But now companies like mine are really looking at how do we change healthcare delivery so that it's really delivered virtually. And in doing that, not replicating some of the challenges that we already have with healthcare, just putting doctors on telehealth, but really thinking about how we can leverage technology to think differently about how healthcare is delivered. So what we do is we have a care team assigned to each patient where they're able to manage their chronic condition like diabetes, hypertension, musculoskeletal conditions, obesity and overweight, and mental health concerns, and really manage those virtually with a care team, and not through video visits, but through asynchronous chat and some remote monitoring. So I'm really excited and lucky, I think, in a lot of ways, to be part of a company that's trying to make healthcare better with the technology that we use versus kind of replicating some of the mistakes we've had before. So that's what we do.
Thank you. And we look forward to hearing more. Jean, let's move to you. Speaking of career pivots, you started in medical school at Stanford and then never practiced. You were drawn into the business and the systems of medicine. So you went to the business school at Stanford and then worked as a consultant at McKinsey for many years. And then you became one of these late founders who is really building something very exciting. Can you kind of share that path from McKinsey to founding Clarify Health? And then briefly clarify what your company does? First, want to make that joke.
No, of course, it's great. And it's awesome to be on with a fellow classmate and friend from way back when and ever since. So yeah, I mean, look, I had always been interested in making a contribution in society. And interestingly, initially, because everybody in my family is a physician, I thought I'd go and do human rights law. And little known thing, I actually applied to law school out of Princeton, got in, decided not to go. And ended up at McKinsey working with the Mandela government on reforming the utility industry. And anyway, realized that I actually really was very passionate about healthcare. Went to med school 50-50 as to whether I'd practice. Now, what's relevant to the journey to Clarify is, as you know, when I spent 8 years at McKinsey in the UK working with the National Health Service there, including a 2-year stint where I ran essentially London's healthcare from a strategy point of view. And the big struggle we had there, even though we could order anyone to do whatever theoretically we wanted, is there was very poor information on what actually was going on, particularly at the level of patient journeys. And one of the things I got to see at McKinsey was what was going on in financial services and at places like Amazon, where even in around 2000, they were starting to get analytics on demand and self-service, and they were starting to do pretty nifty stuff to understand our behavior. And meanwhile, in healthcare, we're giving physicians spreadsheets and Post-it notes with 9-month-old information. And of course, we got into this passive aggressive mode where the clinicians, reasonably so, were saying, hey, okay, you're benchmarking me, but what's the point? And I've always believed that the myth that clinicians won't change to improve the health system was, was that a myth? It's just that we needed to give them the same quality, actionability, and timeliness of information to make better decisions. So think of Clarify as having done what banks do, which is get a massive amount of information on individuals. So we have a data set on 300 million Americans now, and it's all of their claims data, their lab data, their prescription data. And we get everything a bank has when people are applying for credit cards and mortgages, which in healthcare are called social determinants of health and incredibly predictive in many situations, particularly primary care. And we do the kind of analytics now that baseball teams do to understand where people are adding or destroying value in the health system. And so we work with providers, payers, life science companies to help them ideally do a better job of delivering better care and working with their customers. At a 100,000 foot level, you can think of what we're building as the first ever Bloomberg terminal for healthcare.
Exciting. Also the Moneyball for healthcare. So lots of great elevator pitches there, but it is really exciting work that you're doing, Jean. Let's move to hear about Sharon. Sharon, you are another polymath in this crowd. After a PhD in electrical and computer engineering, you've been a life sciences entrepreneur, a venture capitalist, and you're a professor at a course at Princeton on venture capital that I'm told is harder to get into than a Taylor Swift concert. Another long and interesting path. Why don't you tell us a little bit about Valuebased and Optimius?
Sure. Thank you very much. Thank you, Kim, for the introduction. So I'll start from the end. So Optimius is my third startup. It is an mRNA therapeutic platform. 3 years ago, when we went out talking to people about mRNA therapeutics, everybody would ask us, what is that? Nowadays, after COVID, I think everybody knows what it is, and it's been quite a revolution in the world. So so that's my third startup. I guess the first one I started about 20 years ago. We ended up selling it, and in the midst of that, after the second acquisition, I joined a venture firm called Valuebased. And I'll talk a little bit about what Valuebased does, but I've been there for about 13 years. What I do at Princeton is really the intersection of what my life has been. That has been an entrepreneur and an investor. So I teach a course around that intersection, and it is popular. Actually, I think yesterday was the start of the registration, and I've got a lot of students still on waiting list. But in any case, so let me tell you a little bit about Valuebased, which is, I think, the topic of the discussion today. So we are an early stage venture capital organization. We invest anywhere from sort of seed capital, that is a few $100,000, to A and B rounds, so a few $1 million per opportunity. About half of the fund focuses on therapeutics. The other half focuses on non-therapeutics, which includes digital health, devices, diagnostic, things of that sense. We have about 90 investments in our history that we've had. We are currently actively investing out of our, I would say, $60+ million fund. We are a geographic investor. That means that we invest anywhere from, say, Connecticut to Maryland, including the states in between. But we don't invest in Boston. We don't invest in San Francisco. So we are sort of geographically limited by choice. We have made that choice because I think early stage investors need to stay close to their companies, and that's what the path we've taken. I think that's me, and that's us.
Thanks, Sharon. Look forward to hearing more from you. We're going to start a few questions. And in fact, we got one from our audience, which is very closely tied to a question I wanted to ask you, Jean. So let's start there. The question in the chat says, what are the biggest value adds and costs that you're seeing in the data? And as a country, we've been talking about value-based care for a long time now, but we've really only developed systems and payment models around that in a very small number of cases. Orthopedics, like joint replacements being the most obvious. Jean, can you talk about how a company like Clarify is both preparing for and perhaps even pushing the payment system to realize the possibility of value-based care? And also how you've by necessity, I'm guessing, had to develop a variety of innovative ways to get paid in that white space before this transition's been fully realized.
Yeah, your last comment is incredibly telling. People have been saying that value-based care is, and for those on the session today. So value-based care, how do I think about that? It's basically any payment model that isn't paying historical fee for service, where there's a bill sent for the activity, but where some component of what's paid has some link to a bonus that's ideally based on quality or more effective and efficient care. So the most modest version of it is a bonus for hitting some quality metrics. I think we've had that for a decade. The most extreme is when providers themselves effectively become like an insurer and take on the entire risk, right? So fully capitated in the lingo. The reality is only about 10% of the US system is paid in the new value-based way. 90% of it is still fee-for-service. That said, I think, everybody realizes that in order to have a sustainable system in the long run, we have to have a system where clinicians, administrators, and patients go on a collaborative journey of sustained improvement. And if we're going to do that, we have to have a trusted set of information around how it is that we're delivering the care. And so interestingly, I think the best way to go on that journey and to lead people to have the confidence to accept these new ways of getting paid is for people to have a trusted enough and granular enough way to see their performance, and then see that if they were going to make some changes for the clinicians, that they're not going to be massively worse off from a compensation point of view, right? That's a huge issue, or from a documentation point of view, because EMRs have been an incredible burden. Now, in terms of the specific question that was asked in the panel, like what are the most striking or value-added things that we see? Well, number one, any metric that we measure, the difference between the best and the worst is often like not 10%, it's 2, 3, 4 times different. So because we've had such an opaque system, there's actually a lot of, if you will, low-hanging fruit that if we just make transparent enough information available, there should be some improvement. One of the things that's sad and that we're going to have to get a grip on is if you look also at the disparities and the inequities in the way healthcare is delivered, and that's become obviously a very big topic, particularly during COVID. I mean, it just jumps at you. So now what's awesome is, we have targeted efforts like what's going on with Omada to fix very specific problems. And I actually think that's the way forward, is to come up with new delivery models that are manifestly more effective and efficient, as opposed to trying to solve the whole thing top down.
Interesting. I'm going to just pivot. I'm going to try to answer as many questions as I have, but there's a question that's come in that's related to something I wanted to ask Sharon. So Nico Fotopoulos, and I apologize if I'm getting the pronunciation wrong, has asked, what are the emerging areas of healthcare where young entrepreneurs can really innovate it in? I'm not going to, you can answer that, Sharon, but I also want to add, what are the interesting areas of innovation in digital health tech from your vantage point as an investor? And though this may or may not be the same, where are the dollars flowing in your industry now and in the past 12 to 24 months? And how might that guide someone who wants to get into this industry?
Great, thank you. So, as venture investors, we are sort of futurist. We invest in things that are going to be sustainable and going to be around and grow significantly over the next 5-7 years. So if we take a step back and look at our healthcare system, there are sort of 4 major stakeholders. There's the hospitals or providers, there's the insurance or the payers, there's the pharmaceutical companies provide drugs, and then there's the patients as users. I think in all of those segments, there are opportunities. There are opportunities in improvement in terms of health delivery, as John just mentioned. And there's also there's opportunities in reduction of cost in each of those. And then we also have sort of a 5th stakeholder that are the tech company providers that are jumping into it. We've seen a huge move by Amazon in terms of pharmacies. I'll put that to the side for a second. But if I not start from the top, but don't come down to something more tangible, let me provide you a couple examples. In the hospital, sort of in the provider, where there's not a lot of profitability. So the profitability of hospitals in the US are single digit, mid single digits. So the focus is reduction of cost and focusing on operational efficiency. So we invested in a company called Wellsheets. Actually, the founder is out of Princeton. Again, early in his career, just very appropriate. Came out of came out of IBM. Watson knew the healthcare problem and sort of took that on, and it's doing very well. So that's on the hospital side. If you look at the pharma side, the opposite, lots of profitability there, and lots of bottom line. And we have another company called Bainbridge that is focusing on reducing drug waste, which is huge. If you look at the amount of drug that's being wasted there, especially infusion drugs. So there are opportunities at every level. There's huge opportunities at every level. And let me provide another sort of big picture here that I like to say. We know that the science of medicine doubles every 5 years at least. And now let's take a step back and let's think about the delivery of medicine. How much does that evolve? The disparity between those two is where all the opportunities are. So cost reduction, improvement, all that stuff. So just a ton of opportunities out there. And we see that, we get a lot of proposals at my venture firm.
And maybe you can follow up just a little bit to say what's coming in the door now in the kind of during / post-COVID, dare I say, post era.
Great. Now, I'm glad you asked that. So the third part is what's happened with the COVID, of course. So the COVID has accelerated the adoption of telehealth, and I think my colleagues talked about that. So the tools in a fragmented fashion has been around. The technology has been around, but now there's been an acceleration of adoption of this. And to me, it's almost a parallel to electric cars. They've been around for a long time now. All of a sudden, people are sort of adopting that. I think what we're seeing is that almost everyone has used in the past year one mode of telehealth, and they have experienced how easy it is, and you don't have to, you don't have all the inefficiencies of going to a hospital or your primary care physician. So that really has generated a lot of interest in the tools, in the software, and a lot of opportunities around consolidating these fragmented delivery of telehealth, right? What kind of tools do you need? What kind of software tools do you need? What kind of hardware do you need? What kind of diagnostic tools do you need on either side? What do you do with the data? So all of that has been sort of a huge influx. We have seen dozens and dozens of proposals coming the door just the last 6 months in that respect.
Yeah, thanks. So Carolyn, Omada is really tackling therapeutic care model change head on, but a lot of the work that you do, in my understanding, that requires pretty high touch approach, which is not necessarily an easy or inexpensive thing to scale. Can you talk about how you're thinking about reliably and sustainably growing, and how Omada is building a path and valuable lessons for other care model innovations?
Sure. I often refer back to one of my favorite editorials ever in the New England Journal, which was around the origin of the stethoscope as one of the biggest technological innovations in healthcare. You're nodding because I think you know the one. And what it talks about is how the stethoscope was amazing, not because of the technical innovation itself, but because it brought the provider and the patient closer together, so that the provider could really hear what was going on with the patient. And that was very meaningful for me. And it's something that we talk a lot about at Omada, is technology for tech's sake versus something that's actually really going to help people. There's a lot of what I would call gee whiz going on in our field, where people are making devices that sound exciting and sound interesting, but if you actually look at the data, don't in fact help anybody and don't add a lot of value to the healthcare system. And I think this has been a really big problem in our industry, and it's been a problem with us being taken seriously, frankly, as an industry and as a value add by traditional healthcare, because we're not holding ourselves accountable to what's actually helping the patient. And so at Omada, our approach is to think about the technology as enhancement, much like I was talking about with the stethoscope, as an enabler of healthcare, not as the solution in and of itself. And so human-led care and bringing humans at the right time for the right reason, more connected with patients, is really kind of what we do. And that's one of the one of the challenges in traditional healthcare is it's episodic. So you might see your doctor every month, every 3 months for an extremely complicated and nuanced chronic disease. And so you'll get this big list of information, go home, do this list. It's very overwhelming. There isn't a lot of touch points between visits. We have a little bit of things now with patient portals and things like that, but most of that's unreimbursed. So providers tend to not want to lean in there in terms of providing care. So what we're really interested in looking at is using technology for workflow innovation. So essentially bringing providers and the care team closer to patients when they're at home, in their home environment, having people present to give advice, to solve problems, and then when it makes sense and when it actually adds value, putting a device in the hand of the patient to monitor their healthcare, interpret that data with a remote provider who can work with them, and really trying to think about using the human component when it makes sense, and using the technology component when it makes sense, versus just throwing devices. I would ask the audience to think about all of the consumer-based healthcare things that you've purchased over the years, whether it's a fitness device or a home Bluetooth connected scale, and sort of the graveyard of what you've amassed in your house, and what really ended up actually helping you and really changing your health was probably the device that you were using in concert with your provider. It's the device where you were looking at the data and talking to your provider about it, interpreting the data and incorporating that into your care plan. And that's kind of really where we're focused when it comes to human-led care, is really thinking about the technology as a way to bring patients closer to their care team versus replacing it, is how I would summarize that.
Well, speaking of human-led care and humans, we all know, and it's already been alluded to in this panel, that COVID-19's really laid bare many of the inequities in our society, as we see the disease just ravaging lower income, Brown, Black, and Indigenous populations, as well as other vulnerable populations like the elderly. And along the way, one criticism of digital health technology is that many of the early innovations seem to be relevant to those who are young and relatively healthy and already have excellent access to care. Carolyn, can you talk about your experience of health equity at Omada, and whether and how you see digital therapeutics truly improving the health of the most vulnerable?
So thank you for directing this question at me, because I think you already know through prior conversations, this is a passion area of mine. So I cut my teeth in healthcare in safety net populations. Part of the reason I went into healthcare technology is, for me, it's all about scale. It's about impacting as many people as possible. And so to do that, you have to be thinking about underserved communities. And there's a lot of misconceptions around technology in underserved communities out there. People assume that underserved communities will have less access to technology, will have less healthcare literacy and savviness around technology, won't be able to afford it, won't incorporate it, older people won't use it. We have found, not to be dramatic, for that to be just frankly untrue in our population. The over 65 population has the best outcomes in our programs of any population. They enjoy the social connection. We've had to tweak a little bit the type of technology that we use to engage seniors. So they're much more likely to use tablets or desktops. So you have to invest in multiple different platforms. They may be less likely to have a smartphone. When it comes to lower income populations, actually smartphones are the way to go. This is something that a lot of people don't understand. I really appreciate the Pew Research Center. They have the most up-to-date data on what technology different groups have. And their data show that actually the way that low-income populations access the internet is through smartphones. They're much less likely to have home broadband because it's more expensive. So some of these things that you might think are the case actually turn out to be quite the opposite. And I think that it's probably our responsibility as an industry to do more research and to talk about this more. But access to technology is out there. People know how to use it, especially during COVID. People have gotten, I think, just really a quick compulsory introduction to it. And those barriers really are much less than people might think. Now, there is a big area of growth that we still need to tackle, which is language. So our industry is very bad at putting out solutions that are almost entirely in English. Spanish to a certain extent, but having multilingual support in a lot of the technologies that are out there still remains elusive for us. And a lot of that has to do with the tech stack and the ability to update across platforms using language. So someone asked, where in healthcare can young entrepreneurs contribute? I would love for someone to solve that problem, to solve the problem of how do we do rapid updates for multiple languages for platforms in healthcare. That would solve a lot of the problems that we have at our company, because maintaining multiple different languages when you have a complex platform is really challenging. But I think that's a tech problem out there for some bright Princeton CS student to solve potentially.
I love it. Thank you. That leads me right into a question. I'm going to start with Jean and then follow up with Sharon, and which is talking about people. And a lot of people are saying, you know, how can I get into healthcare? What do I do? And Jean, how do you think about in your company the right team as you build it? Obviously, you need a stable of engineers, and I'd love to hear about these days what the most useful background and experience in engineering, data science, you know, machine learning, AI, et cetera is. And then what other kinds of backgrounds do you like to see when you round out the business side of your team?
Yeah, happy to. So we are a technology company that sells business applications to our customers. So we look very much like a software as a service company. On the one end, you're absolutely right. We have engineering, data science, and product development. And there, it's actually been a huge advantage to have colleagues who come from other industries and are bringing ideas and innovations that maybe haven't been thought about in healthcare. So one, when we started talking to our engineers about social determinants of health, because they hadn't been in healthcare before and they'd been in financial services, they immediately assumed that you had to have those at individual level, where most other folks in healthcare do it at zip or block level, right? And so they figured out, including working out the governance with Medicare and HIPAA, how to make that technologically possible. So that's an example of an innovation where we actually want people from outside of healthcare. Now, in data science and engineering, it's the same kinds of things that companies that take big data and transfer it into insights in other industries would want, which means that it's talent that's very, very competitive to get. Now, what you hope in healthcare is because you're working on something that should be higher purpose, that's a part of the interest in folks working there. On the commercial side, where, on the extreme, you have sales reps, and then you have what in technology would be called solution engineers. So those are the subject matter experts that really know a particular element of the industry and partner with sales to convince customers to buy what it is that you're selling. There, it's more important to have an industry background. So typically, people often will have started off in more generalist consulting, but then have gone and worked in the industry. And so we hire people who have worked with hospitals, with health insurers, with pharma companies, who still have a desire and ability to come onto the vendor side. And they are the ones that provide the subject matter expertise facing sales and also facing back into the product and helping the product teams to understand exactly what the unmet needs of the customers are. So for now, someone coming straight out of school, there are roles in engineering and data science for sure. And someone with a passion for healthcare, I think, could convince, our hiring managers that, going into the solution team, as we call it, or the sales engineering team, is something that one could do too. So there are actually lots of avenues to get in. And you don't have to have an engineering background, by the way. On the more commercial side, doesn't really matter, right? It's really a willingness to be a good problem solver.
Yeah, great. Sharon, can you just follow up as you as you think about this with the people that you teach at Princeton, any thoughts on getting into digital health technology, either on the company side as an entrepreneur or on the business side?
Sure. So let me bring my experience as an investor. So, we invest in teams that are passionate about the problems. So what we would like is sort of a founding team that has experienced the problem themselves, and then they can put together a solution team. So, for example, Wellsheet, we had a founder that worked at IBM Watson, and he really understood the disparities of data and its presentation to health providers. On Bainbridge, which is a drug utilization, one of the founders worked in a pharmacy in the hospital for 15 years. So I think you need a team. One part of the team has to be a person or someone who's experienced the problem and is absolutely passionate about the problem, and is has a conviction to solve that problem. And then the other part is surrounding yourself with folks who can operationalize a solution. They have the ability to build a solution around that. I think that's a little bit of an easier task to have, but once you have those two groups together, then you get sort of the perfect storm. I think for my students who graduate out of Princeton, they all ask me about sort of future career. I think what I suggest to them is that, try to get into sort of an early stage company, and learn about the process of what it is to build a startup, and perhaps meet some co-founders who have experienced some of these problems in healthcare firsthand, and start from there. This is just a general sort of advice. There are other exceptions to that, of course.
Great. And obviously, a lot of that wisdom has come from your experience, both as an investor and an entrepreneur. Is there anything else you'd like to share about how your experience as an operator and entrepreneur have really informed and help you in your investment career?
Yes, absolutely. I think being an operator, being a founder, you really appreciate how difficult it is to start something. It is difficult at multiple levels, emotional level, technical level, execution level, team building. So I think having that experience really makes you very humble as an investor, and make you feel like being an investor is really is an honor, frankly, to work with an entrepreneur. It's not something like, oh, we have money, you listen to us. And I think what we teach, what I teach at Princeton is that the perfect storm is not only when you have a passionate founder and a passionate investor, but also when these two are 100% aligned in terms of their vision, their mission, where the company has to go. So, often you see in the news, these two groups sort of battle. In reality, the real successful companies are those who have, full alignment on the entrepreneur and an investor. And for me personally, having been on both sides of the table almost all my life, I feel that is really a must to have. It's just, you have to have that. Otherwise, it's not going to work. Yeah.
Great. I will say from my own experience, I just finished reading the book called Range by David Epstein, which is a few years old now. And he really talks and gives a compelling argument that moving around and really both reading and experiencing widely, that sampling a lot of different things along the way is the way that people become the strongest, especially in environments that require innovation. And so I myself decided I was going to go to medical school as a sophomore. And then I decided there was so much that Princeton had to offer that I majored in religion. And I did that because in religion, you can study history and art and all of these other things. And I think my career certainly has been a ranging career. And I feel like that adds, like Jean was saying, when I come into the room, I can bring things that maybe the people who've been in a straighter pathway just can't see. So all of you are great examples of that range as well. I'm just going to ask a more specific question and from our participants. So this is, I think, about reimbursement and payment models, which has been very difficult in this emerging industry. So this person, Emily Kim, says, many digital health or prescription therapeutic companies like Pear and Omada and Akili are pursuing reimbursement and coverage as a pharmaceutical. And I know, Jean, you have some reimbursement pathways, if I understand correctly, that also involve the pharma industry. And she's saying, as opposed to sort of a hybrid therapy or device-based therapy where payment pathways are more innovative in this country and in other countries. And can you just maybe, we'll start with Carolyn and then move to Jean, talk about how people are really searching to find payment models, to find a way to get this work done.
The first thing that I'll say is we need to, probably it's time to stop using the term digital health because it's just healthcare at this point. And so when you ask about reimbursement, the question would be for what, right? For what type of thing are you talking about? So in my world, we deliver direct services, direct medical care to people. So there's a certain type of reimbursement that we would have access to or want to do. And Akili is a packaged intervention that is working very much like a therapeutic. So it made sense for them to go through an FDA clearance pathway to get that reimbursed as almost like a pharmaceutical, a pseutical, I call it, because it's not really a pharmaceutical, it's not a pill. But that makes sense because it's a canned intervention that is supposed to, you do this and you get this outcome. Paratherapeutic, same thing. But actually that is the exception versus the norm. The vast majority of companies in my space are actually not reimbursed through claims at all. They're reimbursed through direct invoicing directly with the employer. That is not a good thing, I don't think. That is not a sustainable thing. It is a go around that employers use in order to get access to these services because they aren't embedded in traditional healthcare. So I think the guiding light here is for solutions like ours that really are care delivery organizations, and we're not alone. It would be the same for a Lyra or a Livongo or an Onduo or any of these companies that you hear about, for them to really be considered as healthcare providers. And so really what we should be doing, which is what we are doing more and more, is becoming an in-network provider under the health plan. And so just like you can choose to have your care at where Kim and I both practice at UCSF Medical Center, you could also choose to get your care at Omada Health. And we would be just another healthcare provider that you have access to in your network. And we would submit medical claims just like any provider would. We're starting to see this with some of our partners. In fact, we are now getting listed for our physical therapy services. You go in to try and find a physical therapist in your area, and up comes Omada Health because, hey, guess what? We're in every area because you can get us, in all 50 states. And so that's, I think, really where we need to go is if you are in fact providing clinical grade care, you should be reimbursing through medical claims. You shouldn't be invoicing or doing these other things. And if you're providing a direct intervention that has been studied as such, as a canned thing that has a particular outcome, well, then you should be pursuing FDA clearance. But this invoicing thing is just a go around that needs to stop. But I'm really curious, Sean, what you think about this too, because you're in kind of a different area of healthcare, and the way you get your checks come from a different place, I think, than ours.
Yeah, I mean, where we meet is, I'll give you an example. Some of the payers, when they bring on new members, many of them they don't have great information on. They ask us to use our knowledge to risk stratify the population and suggest who should be matched, for example, to nurses going in the home or phone calls or simply to a PCP, and they'll be okay. You can imagine that some of them are starting to ask, well, should they be matched to Lyra, Omada, et cetera. So there's this notion of, if for a particular cohort of individuals is a particular intervention value for money. Now, in terms of what you laid out, I mean, I happen, I think, to agree with you, which is if a payer at the extreme says, hey, I will put Lira or Omada on formulary and the physician can prescribe that intervention, why could you not think of it that way? I mean, we have more than pills now that can be very useful in helping to accelerate to better outcomes in the context of a patient journey. Like that's how I think about it. So I think the beauty of some of the innovation now is we can move to more than just things that you pop into your mouth that can make a massive difference in terms of how you do moving forward. But it's important that whatever the interventions are, that we put them on an equal footing from a payment point of view. And I hear a little bit of that in what you're saying, and I have a lot of empathy for it.
Great, thanks. Sharon, as an investor, do you have any perspectives on this that you'd like to add?
No, I think it was well covered. I won't add anything to that. I think both sides were well covered.
Great. We have a pretty specific comment or question that I'm not quite sure who feels ready to answer this. So jump in if you do. David Chuang asks, what do you think of Microsoft's acquisition of Nuance, and can Amazon expand Alexa to healthcare? So I think, maybe we can just broaden this to be I mean, maybe answer the question directly, but really, it's a question also about big tech and how big tech is getting involved. So if anybody wants to comment a little bit about
I'm happy to start and then, have others chime in. So Nuance essentially has software called Dragon, which is used a lot in the healthcare context to translate, the spoken word of clinicians into notes and various things. And, I think the idea, you're probably right, is for that kind of technology to potentially go into an Alexa, and an Alexa then presumably be able to be used to dictate and organize information in EMRs and various other things. Makes perfect sense. It's the kind of workflow improvement and time-saving technology that we need in healthcare. Clinicians are partly burning out because of the burden of documentation, and Kim and Carolyn, I'm sure you're all too familiar with it. And also I think the other angle for me is, if you think about how we improve the health system, I think a really interesting lens to look at is, how do you optimize the experience and outcome of an individual patient journey? Because if you had every single patient journey stacked on top of each other in a year, you by definition have the entire healthcare spend. And where the world is moving in the context of a patient journey is omni-channel. So telemedicine is a great example, right? We now are not forced to take a half a day off of work and spend 3 hours going back and forth to spend 20 minutes at the Oracle at Delphi of the clinician, because, people are now actually willing to, see you on the screen. Similarly, if your preferred mode of interaction is the text message or a phone call, what's wrong with making that available? And I could see an Alexa type system being a way to provide certain kinds of information to patients in the context of their journey in a very time efficient and helpful way. So it's not just the use case for me of helping clinicians to document in a less time intensive way. I think it could be deployed in the context of education of patients in a very powerful way. And it would just be another channel to help the progression of the journey in a more, useful way.
Thanks, Sharon or Carolyn, anything to add to that?
Yeah, I mean, I can jump in a little bit. So, we had an investment in a company that was like an Alexa, but with reminder for taking medication. So, what really learned from that was that, in order to use these technologies, you have to be very application specific, and that has to solve a real problem. So, and that problem has to be huge. Otherwise you do not get the adoption or the adherence that you need. So it's nice to have Alexa to ask, how's the weather today? But if you want to use Alexa for a medical or healthcare application, you need adoption and you need adherence over time. And the only way you get that is if it's really solving a major problem, something that is of high need for the patient and for the user. So that's what I would suggest. I mean, I think that you get into it only if you focus on those applications.
Yeah, and Carolyn, we saw a lot of this in the work I did at Kaiser as well. And I know you guys think about this, we often call it engagement in the digital health tech sphere. And that's very much what you guys wrestle with in behavioral health, in treatment and prevention of obesity, in hypertension, these kinds of illnesses where often people are not really incented internally to do the kind of changes we need. That engagement is vital. So maybe you can talk about both the potential solutions like we were just discussing, and really about how you guys have really thought about and won in many ways in the engagement game.
Yeah, thank you for the softball question, Kim, because this is something that with all humility, I've had to learn at Omada. I mean, the way that we get people into our program is they get referred by a provider or an employer email, and no one's going to click an email that says click here for someone to bother you about your diabetes, right? Like no one's going to click that email and want to go and engage with that platform. That's just not enticing, right? So with humility, what I learned at the beginning was we were developing a very rigorous diabetes program, very medically heavy, all the right things, but it's boring and people don't want to do that at home. They don't want someone to bother them about their diabetes, even though, we want to help them get healthier. They it's just not fun. And so I think where the magic happens is the combination of those elements of engagement that come from tech companies that are fun, engaging, we use the word delight, and makes healthcare a less serious, boring, and sad kind of endeavor for a patient. And that's, I think, where the win is. We were talking about big tech before. I think one of the problems with big tech in healthcare is they come in wanting to change the healthcare piece and forget the piece that they really bring, which is the engagement and the fun part. So it's been our communities that have gotten people to stay in. It's been our user interface. It's been the fun messages that we send people, the attitude of our coaches, the design of our content, remembering people's birthdays, congratulating people on the birth of a child, building all of these things into an algorithm that really make people want to spend time with us. And in addition, we help people with their diabetes. We do all of that together. But I think that the truth is, if you don't get engagement right, people vote with their feet. In a medical clinic, if you make an appointment with a patient, they will show up and they're stuck with you for 30 minutes. I mean, you literally close the door and they're like stuck with you in the room, and you're going to do what you're going to do with that person. But with tech, they can click out of your system in 5 seconds and then they're done. And then they're done with your intervention. So if you don't get engagement right, you really are not going to have the impact that you want to. And that's where I would like to see big tech help us more as a healthcare industry, because we don't know how to make healthcare fun, engaging, and interesting. We know how to make it boring and hard, but we don't know how to make it engaging. And I would like to see more of that from big tech, to be honest, to help us do more of that.
Yeah, I agree. Big tech, small tech, gaming companies and commerce companies really know how to engage people. And so I think that a lot of that cross work can be really important. We're running short on time. I have one other question that I'm going to sort of try to get us to address quickly, which I think is an interesting one, which is, do digital healthcare tools work better in countries that have socialized medicine and insurance versus private medicine insurance? And I'll just say, I practiced in Kaiser Permanente here in California for over a decade, and we did telemedicine well before everybody else. And we were incented to use the right tool, as Jean referred to use the right tool, whatever tool made sense to get the patient the care they needed. And so some things I could do by email easily, and some things I could do over phone. And then patients and their parents, in my case, because I'm a pediatrician, parents didn't have to leave work, patients didn't have to leave school. We can do a lot of things in an integrated health system that's all paid internally. So that was certainly my experience. Jean, how about when you think about your experience at the NHS, also a completely consolidated system, how do you think about these kind of digital tools being rolled out there versus in America?
So I think ultimately it's more about what are the incentives to pay for innovation. And unfortunately, in most government, in most NHS style or Canada style systems, because the way healthcare gets paid for is either the hospital or the health region gets a budget for the year, and that budget has to deliver all of the care. There tends to be very little left to experiment with new things. So Kaiser, I think, had the advantage of being in the US system, run efficiently. There's a surplus and philosophically, it's geared to wanting, it was one of the first systems to bring in an electronic health record, right? Even though it was in a system that didn't necessarily need to be that fastidious about claims. And I think Kaiser is one of the few places that brought in an electronic health record with improvement as part of and quality as part of the real rationale. So interestingly, I'm more bullish on the US being the place that gets this kind of digital innovation, because it's funny, because of the inequality in our system and the way it's structured as not one size fits all, there's more of an ability to experiment. I think from an equity point of view, we then need to take the successful experiments and make them available for everybody, right? And I think that's how we balance the contradictions in the system here.
Amazing. So much wisdom. I have so many questions to ask, and as do the people who are on this panel. But I think, Beth, did you want to come on and just give a closing thank you to everyone? I myself will really want to thank you, Carolyn, Sharon, and Jean, for giving us your insights today. It's been just great, and we hope we can bring you all together again.
Thank you, Kim.
Thank you. Thank you all.
Thank you, everyone. Hi, this is Michelle from the Princeton Innovation Center Biolabs. I want to really thank all the panelists. Thank you for your participation and rich conversation. And thanks to everyone for taking part of your valuable day to join us for today's webinar. I hope you found the information useful. We look forward to seeing you at many other events. And if you'd like to know more about Princeton Biolabs, please feel free to reach out, and we'd love to tell you more about our co-working space for life science startups. Thank you, everyone. Have a good afternoon. Have a good evening.